Good morning or good afternoon, wherever you are. We are privileged that you have decided to listen to this presentation, the title of which is Never Compromise Safety and Efficacy for Your Patients with Pure Hypochlorous Acid Based Wound Cleansing, or what we call in short, pHA wound cleansing. My name is Debashish, and I'm the Vice President of Medical Affairs for Ergo Medical North America. It's a real privilege to be talking to you all. I have two absolutely fantastic presenters with us today. One is Dr. Kevin Wu, who is in an academic as well as a clinical role in Kingston, Ontario. And he's hugely well published and one of the leading opinion leaders in the field of wound healing and patient quality of life. The second speaker we have is Jolene Heil, a very experienced NSFOC, who also has a master's in clinical sciences and wound healing from Western University in London, Ontario. Between the two of them, they will present to you the science behind the safety associated with hypochlorous acid, as well as its efficacy as a preservative, and its demonstrable ability to remove germs and necrotic tissue from the wound bed. So without much further ado, I want to introduce Dr. Wu to you, and please go ahead, Dr. Wu. Thank you so much.
Great. Thank you, Debashish, for a very kind introduction. So it's a privilege for us to be presenting to you about this innovative wound cleanser called pHA. So as Debashish mentioned, Jolene is joining me on this presentation. We're going to go through a little bit of the science and also talking about some of the clinical cases, how we actually apply the pHA in terms of improving patient outcomes in a few scenarios. So it will be an interesting dialogue with Jolene and with you, hopefully. So as you can imagine, I think wound healing is a big challenge for everyone in the field. Chronic wounds do not always follow a healing trajectory, and it is one of the most expensive expenditure in healthcare system in terms of trying to promote better wound healing. I think at the end of the day, we're trying to look at balancing between safety, making sure the product we use, whatever devices we have introduced to the wound healing process is safe and comfortable for the patient. At the same time, we'll be able to achieve the efficacy and being cost effective at the same time as well. One of the major factors that I've been talking about on many occasions, what really render chronic wound become more chronic is the problem with infection. So I think that's the impetus for us to look at the different solutions and different ways of addressing local biofilm, local infection problems, so we can prevent other complications from happening and also promote better wound healing. As we have talked about a lot of solutions we have used in the past, we actually no longer really recommend them to use on a routine basis because of the cytotoxicity. Fair enough, a lot of these solutions we use potentially can kill bacteria, but at the same time, because they're so corrosive, so toxic, they can kill all the good cells, growth factors, granulation tissue at the same time as well. I think one of the good solutions for comparison is Dakin solution. And we'll come back to talk more about Dakin and compare with the pHA solution that we'll be talking about today. And as we can imagine, some of those really toxic solutions, we basically end up sacrificing the key ingredients, the cells that are necessary for wound healing. So let's take a look at what this pHA is. It's just easier to say pHA than pure hypochlorous acid or pHA. So it is a natural molecule that and I'll show you a little bit later that we actually produce from the body with a pH of 3.5 to 5.5. And that pH is so vital in terms of maintaining the stability of this ingredient, this molecule, so it can exert this antimicrobial activity in the wound environment. So it has to be controlled in a very, very tight range. Anything lower in the pH or high in the pH, the solution is not going to work and is not going to have the same property that we expect to see. Acidity pH is hostile to pathogens and biofilm, and we recognize that by maintaining a wound with its acidity is actually create an environment that is not conducive for pathogens to grow. And it's part of the vital process to maintain wound healing, because a lot of times bacteria, in fact, will produce other agents, solutions, and creating an environment that is more alkaline and such that the bacteria can grow better. So the pHA cleanser, VASH, is a non-toxic solution to tissue. And other cleansers without pHA may be cytotoxic, particularly if they contain hypochlorite. And that's what the key ingredient in Dakin solution. And often people get confused about hypochlorite and pure hypochlorous acid, and they're very, very different things. And in fact, Dakin solution arguably is one of the most toxic solutions that we can see in the market in the clinical practice area right now. And remember, when the pH level is above 5.5, the hypochlorous acid cannot exist. It has to be controlled and has to be created and maintained in a very, very tight range pH. And we also, and we'll show you some more data that hypochlorous acid can remove biofilm and versus hypochlorite cannot remove biofilm. And that's, I think, is a very, very important message. It's a very corrosive agent. In fact, it can damage the wound tissue without touching the biofilm. And remember, the wound pH change is a very, very gradual process. People often think that, well, by applying some solution, we can change the pH right away. And that's not always the case. It may take a little bit of time, either from the soaking or few applications in order to modulate the pH and revert that back into the environment that is conducive for wound healing. So let's go through a little bit of the science, and of course, there's a lot of interesting discussion around what hypochlorous acid is and why is it being introduced in the wound healing arena. And in fact, hypochlorous acid is one of the natural defense mechanisms. We ourselves produce hypochlorous acid in order to kill bacteria. So it's one of the ingredients produced by neutrophil. And as you can see in the formula here, through a couple of enzymes with the dimutase superoxide, it can promote the creation or manufacturing of the hypochlorous acid, and it can have the potent property to kill bacteria. So why is pH 5.5 so important? Again, going back to the discussion we had earlier, comparing between the hypochlorous acid and hypochlorite. So just a reminder that it has to be within this very, very tight range. As you can see on the slide, it's a very, very beautiful illustrated slide. It may be a little bit complex, but it really driving the message, hopefully, to home that, you know, with the right amount of pH within this range, this very, very narrow range in sort of bluish gray color, the hypochlorous acid can exist and be stabilized. So if the pH is too low, then it turns into this gaseous form. And of course, it won't be able to be applied on the wound environment. Versus if the pH is too high, then the hypochlorous acid is going to convert into hypochlorite. And as we mentioned earlier, hypochlorite is actually very, very corrosive, very damaging, very toxic to cells, but may not be as effective against bacteria and biofilm. So what the company can have done with Ergo has done is to use this sort of electrochemical manufacturing process to stabilize the solution to create this right pH environment for the hypochlorous acid. And if you may ask, where's the data? Where's the evidence that hypochlorous acid is effective against biofilm? I think this is a wonderful study. And if you are interested, we can provide the reference to you as well. So what you demonstrated on this series of slides is the basically describing how hypochlorous acid is effective reducing the amount of biofilm, whether it is Staph aureus, whether it is the different types of the biofilm structure and the protein matrix. So you can see that clearly that over time, the significant reduction of the bacteria, and whether it is the planktonic state or the polysaccharide in the biofilm environment. So again, I think hopefully you get the message that pH does matter in terms of wound healing. We want to maintain a wound that is acidic to promote better wound healing. And I think in the research, when you look at the literature, why pH is so vital to wound healing, there are a number of factors to remember. As wound healing continues to improve, it has to be in this acidic environment to allow protease to exert its activity so it can continue to remove pathogens, continue to clean up the wound bed. It can also create a hostile environment for bacteria to grow, and also at the same time, in order to enhance the collagen to be removed by the protease or by the other white blood cells, has to be in this sort of right pH environment. We also understand that the right pH is important for angiogenesis to stimulate new blood vessel growth. So hopefully we are able to convince you that the wound pH is so important for wound healing. And now you can appreciate why we want to make sure the solutions we're using, whether it's for compressing, soaking, and cleaning, has to be the right pH. And at the same time, the right pH would be able to stabilize the key ingredients that are important for the bacteria killing. So this is just to really give you a idea in terms of the broad spectrum of activity that pHA can attack, can address. And what this slide is showing us is with the alkaline environment, a lot of cleansers that we use potentially can change and modulate pH level such that it becomes more alkaline. I think bacon solution is a very good example. And what you can see that with the conversion of wound being more alkaline, it can promote bacterial growth. And whether it is Staph aureus, E. coli, and Pseudomonas, Klebsiella, even fungal agent or the Candida agent potentially can thrive better in an alkaline environment. So by producing or by introducing more alkaline solution, by introducing more Dakin solution into the wound, we're actually going to slow down the healing process and creating an environment that is more conducive for bacteria to grow. So I think that that's a key concept around wound acidification and why it is so important as part of infection management and wound healing. And moving on to the international consensus guideline, a lot of you may have read the last version published in 2016. They have released another version, 2022, the most up-to-date version of the principles of best practice recommendations. As you can see that this guideline there's a lot of key experts, wound clinicians across the globe get together to look at the evidence. They come up with recommendations for the best practices. And they do recommend the use of VASH and the pHA to address local bacterial burden. So I think that that's an important message that they have highlighted in the document. And there's definitely a lot more clinical data and cases available. And today we're going to show you a few cases and hopefully that will help you to understand how this solution can be used. So I want to share with you a first case. It's a 70-year-old woman with chronic leg ulcers on both legs, in fact. As you can see, we're actually puzzled by the etiology. And she told us that it was caused by, it was a small wound at the beginning, and someone put some hydrogen peroxide over it, and boom, it exploded into multiple lesions. I'm not quite sure how true it was, but regardless, the legs were not too edematous. So it's not really consistent with venous disease. And you don't really see a lot of venous changes on both legs either, not enough hemosiderin to be concerned about, and not even any sort of signs of lipodermal sclerosis. But definitely a lot of drainage, and her heart failure is not bad, it's well controlled, and she's not spending a lot of time in a chair to develop dependent edema either. So we're very puzzled about the exact etiology. But despite that, what we're trying to do is to manage those wounds better. We tried many different ways, and a lot of the dressing she was averse to, she developed reaction according to her. And we tried different solutions as well, including povidone iodine, it burns. We have tried also acetic acid, because with the increased amount of drainage, it was promoting Pseudomonas growth. And of course, with the pain that she was experiencing, just a little bit of that acid on the skin, causing an intense amount of pain. It was excruciating for her. So we just basically have been using saline solution to clean the area. And of course, with those wounds, you can see there's a lot of drainage, and we were concerned about the local pathogen and local bacterial burden. And we were actually quite pleased to have the sample using VASH and use it for the first couple of weeks. And the patient told us it wasn't painful, it was comfortable, and we used it as compress and apply on the skin for a few minutes, and then follow with some saline. At the time, we're not quite sure how to use it, so that's why we follow with some saline solution to wash it off, just in case that she developed more adverse event or adverse reaction to any type of chemical agents, given her sensitivity to multiple things already. So as you can see that over time from week 1 to week 8, there's a significant improvement with the reduction in some of those lesions, and some of the areas start to actually closing in and drying up and less exudate being produced. So I think it's a good indication that if you think about all the common signs and symptoms associated with local infection, whether it is increased exudate, increased smell, increased pus formation, and also slow down the healing process, I think we're able to convert this really challenging wound, very difficult to treat wound, to a healing environment. And as you can see, by week 8, this wound is actually a lot better, and the pain level reduced from originally about 8 out of 10 to about 2 out of 10. And initially, again, because of the pain issue, because of the sensitivity of the skin, it took us about 35 to about an hour time to perform a dressing change, because we have to be so careful, slowly soak up the dressing to remove and to avoid skin breakdown, further skin breakdown. By week 8, we're able to do the dressing within 15 minutes because the pain issue no longer a concern, and it has improved so much that we can actually do the even do some debridement to remove the hyperkeratosis. So I think this is a very good case to illustrate how the VASH solution can be used as a compress to really help to modulate the local environment to change the bacterial burden. I'm going to give you another case. This is a 46-year-old man with diabetes. As you can see, this is a amputated site post-amputation. And we did try to do some debridement from time to time to really clean up the wound bed, as you can see on week 1 at baseline before we give VASH solution a trial. There was some sloughy tissue, unhealthy tissue, and the areas is very difficult to dig into. It's very tenacious, very stubborn, fibrinous material. So again, we use the VASH solution as a compress, apply that on a gauze material, put it on the skin, on the wound environment for a few minutes, and allow the agent to interact with the local wound environment. As you can see that over time, we're able to gradually improve the quality of tissue. One of the nurses said, wow, this solution is so good. It's actually melt all the devitalized tissue. Well, I wouldn't say this is actually melting the tissue per se, but it does help to remove and help the body to promote this autolytic debridement process in a better way by reducing the bacterial burden, by creating a right environment for the neutrophils and macrophages to work its magic so it can clean up the wound in a better way. So by week 4, you can see that there's some good granulation tissue, there's less percentage of yellow, fluffy, fibrinous material on the wound bed. Okay, going to share with you another situation, a 67-year-old woman with what we think is venous disease and even lymphedema. As you can see, the digits, the toes are quite congested with lots of fluid there. At the same time, she has diabetes. And on baseline, because we've been using compression to help this individual, so because the toes were always closed, creating environment for bacteria, for fungus to grow, you can see this significant amount of maceration between the second and the third toe environment. At the time that I saw this patient, again, it was very, very painful. And the infectious disease person was not so keen about introducing antibiotics because this patient was being treated with multiple courses of antibiotics already. So there's some hesitancy of keep introducing antibiotic treatment. So I thought, well, okay, let's give some topical treatment a trial. And we tried some povidone iodine for a few days. You can see that after 3 days of treatment with povidone iodine, not a big difference in terms of the quality of the tissue. There's still maceration. The pain is still really, really bad. And there's really basically no change in terms of drainage from the local area as well. So we decided, well, it's time to really switch to something perhaps a little more effective that actually will work for this individual. So we switched her to the VASH and sort of in order to keep the area nice and dry, we weave the AMD, the antimicrobial dressing ribbon, around the toe area. One is to absorb the excess drainage and also to give a little bit of that compression on the toe area as well. And then we apply the normal compression from the base of the toe to the knee in order to control the edema. So you can see after 2 weeks of treatment, this combination of using VASH to clean and compress, and then in between the co-band, the compression dressing changes, we continue to use the AMD ribbon to weave between the toe web spaces. You can see the huge improvement after 2 weeks. All right, another case, and this is not the leg this time. This is right around the hip area. Is a 25-year-old, a young person living with obesity, and he actually had a motor vehicle accident result in the hip problem. He was transferred from acute care to rehab hospital in order to regain his strength. He was working so hard. He actually had lost about 25 kilograms during hospitalization. He would just want to get back to be a healthier person. He recognized that being obese is not very good for him. And this opportunity, being in hospital and being sick and being experiencing the near-death experience, perhaps really a wake-up call for him. So the area, unfortunately, during the hospitalization before coming to us, it dehisced and result in the osteomyelitis. So he was treated in the hospital before transferring to our rehab hospital for rehabilitation. So, well, I think it set the stage that this person was highly anxious. He was worried that this wound is going to turn south again. There will be infection. He had some really, really bad experience with some of the wound care in the acute care environment. I'm not finger pointing that certain environment has better wound care, but some people do have some unpleasant experience from time to time. So unfortunately, he did have some of those encounters. So at baseline, the wound doesn't look too bad, but there's still quite a bit of drainage. There's no smell. There's a little bit of local edema. And we really want to give him some confidence that we know what we're doing and able to control the bacterial burden and to able to prevent further infection from happening. So we've been using VASH solutions since he came to the hospital. And on week 1, you can see that the wound continued to be relatively healthy looking. Week 3, week 4, by week 4, you can see the significant improvement, the epithelialization of the area, the reduction in the wound size. He was actually literally quite ecstatic that with the outcome and what the solution and what the wound care has able to help with the healing process. He was very, very impressed. And of course, we're happy that he was impressed. So the last case I want to share with you, another leg ulcer patient, 54-year-old man with bilateral venous leg ulcer. And like the solution idea for a number of reasons, especially in this type of situations, when we have to apply compression therapy, a lot of times we don't really change the compression bandages on a regular basis, not on a daily basis for sure, sometimes 3-5 days, even sometimes a week. So by controlling the local burden, by addressing the skin hygiene, perhaps we can reduce the pathogen, reduce the environment that promote bacterial growth. So that's one of the reasons why we use the VASH solution in this case, even though it may not look obvious to you that there's some infection problem, but we want to prevent some of the infection or some of the pathogen from growing in the local environment. So on baseline, you can see the legs and almost circumferential ulcers developing around especially on the left leg. And we continue to use the VASH solution. And by week 5, week 6, you can see a significant improvement, reduction in the wound size there. After the VASH solution, we use the inidine dressing, the povidone with the propylene glycol as a topical treatment to prevent bacteria from growing underneath the compression therapy. That's why you see a little staining on the skin there. But I think overall, I think we were very happy with the combination of using a VASH solution as a cleaning agent, as agent to reduce bacterial growth, as part of the skin hygiene regime, and then continue with our topical antimicrobial treatment, and also, of course, all the other best practices consistent with the step-up, step-down modality when we think about wound healing. So I think in conclusion, I think we were able to achieve some amazing outcomes with the use of this solution on a number of occasions, different types of wounds. So I'm going to pass on to Jolene. She's going to share with you some more interesting cases. Jolene, you're on.
Okay, so thank you, Kevin. That was a very interesting aspect of the scientific and the practical aspects of using VASH. So my name is Jolene Heil, and I am an advanced practice nurse, and I work at Providence Care Hospital in Kingston, Ontario, and that is a rehab center for active patient rehab, complex continuing care, palliative care, and we also have an inpatient mental health population. So I am going to talk a little bit about some practical cases that I have for seeing patients and using the VASH. I'm going to start actually with a personal story about how I started using VASH. I was cooking and with a cast iron frying pan and some grease on the stovetop, and I am clumsy and managed to get a large burn on the back of my hand, on my knuckles, the back of my hand, and up my forearm from the hot grease. Of course, as any good NSWAC does, we have a sample cupboard. And I knew I was going to need some antimicrobial and something to help with pain for this burn. And I went into my sample cupboard and the VASH was staring at me. And I thought, well, I haven't used this on a patient yet. I don't know if it's going to sting or not. As you can imagine, a large burn like that is quite painful. So I did open the bottle. It does smell like Dakin's solution when you open the bottle. So of course I was a bit taken aback by that. But when I soaked my hand in the VASH, there was no pain whatsoever. So it did not provide any pain to my burn at all. So I did continue with the VASH soaks with every dressing change. And I had a great result from my burn. It healed in a predictable manner, and I now have good skin on the back of my hand again. So my personal experience with VASH is what actually prompted me to start trialing it on my patients. So this patient, the very first one, is a 56-year-old female, and she had bilateral lower leg wounds for about 5 to 6 years. So they were significant wounds. She did have a diagnosis of venous stasis with lipodermatosclerosis. She had had a number of extremely painful dressing changes. Because of this, she had an aversion to any antimicrobial dressings, and the only thing that she would allow on her legs was Vaseline and a non-adhesive gauze pad, and these dressings were changed daily. So this patient had actually been admitted to acute care a number of times over a 2-year period. The reason she ended up in rehab was because she was deconditioned from all of her acute care stays, from her infections, and she had so much drainage coming out of her lower legs that she was actually diagnosed with acute kidney injury and had moments of opioid toxicity because of her kidney injury. So she was admitted to one of our rehab floors, and she was quite challenging. She had a lot of experience with painful dressings. And so this is where my challenge began. So what we did is we immediately modified her pain regimen. We started her on a systemic antibiotic because she had a lot of bacteria in these wounds. Once we got a hold of her pain, she was able to tolerate a light compression with an Una-paste boot. And we decided to start the Vache soaks. So she had used an antimicrobial wound cleanser in the past. And what she found was it worked great when she started using it, but after a few months of using it, it would stop working. So we opted to try something different, and we used the Vache. And this is where we ended up. So we started, this is her right leg, and her wound size was 31 by 24 centimeters. After 8 weeks of using the Vache soaks, she was down to 27 by 17 centimeters. And you can even see the difference in the condition of her leg and the difference in the condition of her wounds. So she had a layer of yellow slough on her wounds that she had had for a long time. It wasn't abnormal for her. We weren't able to do any type of sharp debridement because of the amount of pain that she was in. So we continued with the Vache soaks. We continued with the Una-paste boot. And this was about 16 weeks post initiation of the Vache soaks. So she was now at 16 centimeters by 14.5 centimeters. And I can actually tell you that I saw this patient again yesterday, and her wound is now 9 centimeters by 5 centimeters on that leg. And she did mention she is continuing to use the Vache soaks at home. She did mention that there was a disruption in her ability to get the Vache for a little bit. And she said that the yellow slough started to come back on her wound, and she was noticing a lot of the Pseudomonas staining and everything against her on her dressing. So she had received the Vache back just a couple of weeks ago, and she was very happy. And she's noticed her wound has turned into a positive again. So this is her left leg. So we had wounds on both legs. So we started with 17 centimeters by 11.5 centimeters. By 8 weeks post initiation of Vache, we had a wound that was progressing quite nicely. And then again, this is her wound at 16 weeks. And then yesterday when I saw her, this leg is actually completely closed. So her report, she had no skin sensitivities with the Vache, and she had no stinging or burning. So she was quite pleasantly surprised. And again, she thought the same thing that I thought when I first took it out of the bottle, and I would pour it on a roll of Curlix, and I would wrap her leg with the soaked roll of Curlix, and that's how we soaked her. And she immediately thought, oh my goodness, she said, it smells like bleach. And I said, yep, it does, but it doesn't sting. And she said it was absolutely right. There was zero stinging or burning. So the next case that I want to tell you about is a 75-year-old male patient. So he was admitted to rehab after a bilateral above knee amputations. He had had peripheral vascular disease and infected lower leg ulcers with MRSA, and ended up with bilateral above-lean amputations. He is diabetic. We had him on adequate pressure redistribution, and he had independent bed mobility, so he was able to roll back and forth in his bed with no problem at all. He is continent of bowel and bladder, yet he presented with this area on his buttocks that we were a bit perplexed about. We treated him for candida for about 10 days, but there was minimal improvement of this. And he had these odd little pustules that were popping up on his buttocks. So we did a CNS of the pustules and they were MRSA positive. We ended up starting him on the VASH soaks, and we soaked his bottom for 10 minutes at night and 10 minutes in the morning. And we did not apply any other dressings to this. We just did the VASH soaks. And this is where we ended up about 4 weeks later. So he had a very clear buttock. He does have a little bit of shearing because he's sliding himself across the bed. But his bum actually cleared up quite nicely. And he even wanted to take a bottle of VASH home just in case something like this happened at home. My third case that I'm going to talk about is a 52-year-old female with hidradenitis suppurativa, early stage 3, and she was quite complex. She had been on long-term prednisone use. She had had previous surgical interventions, so INDs of these sinus tracts. And then she came to rehab because she had had bilateral hip fractures, and she ended up with a necrotizing infection of her left hip incision, which we treated with negative pressure wound therapy. So this patient here was quite resistive to having any more surgical interventions for her hidradenitis. She was on a disease-modifying agent and was taken off of it because of the necrotizing infection on her hip. So at this point, when we received her, she was not on any disease-modifying agent. She wasn't on any prednisone. She was basically on nothing to treat her hidradenitis. So she had a number of these abscesses that connected all underneath the skin. They were extremely painful. She was getting a lot of skin irritation from all the drainage. And so I knew that I could not do anything to stop these abscesses from happening, but I thought, what can I do locally that can just help her a little bit with quality of life? So I started VASH soaks on her with her dressing changes for 10 minutes at a time. And in about 2 weeks, I took another picture of some of her abscesses, and I did notice a difference. So as much as we couldn't stop them from happening, her skin condition overall was improved. So this was her hip incision, and then she had a number of these abscesses in and around her hip incision and up into her abdomen and into her groin. So you can see that the skin condition actually did improve with the VASH soaks, and that was the only thing that we did different in these two pictures. So the patient reported no stinging with the use of the VASH. She did notice a significant decrease in the odor, especially in the groin areas. And the nursing staff also noted a decrease in the odor. And one of the things that she said was, I always want to use this product because I just feel cleaner with it. And I thought that was really important for her. So this is my last case. So this is a 57-year-old male patient. He has a history of cerebrovascular accident with right hemiparesis and expressive aphasia. He had a fall at home, which resulted in a left shoulder subluxation. And then 1 month later, he was diagnosed with a septic left shoulder joint. So he was treated with an open surgical washout with negative pressure wound therapy and IV antibiotics. So on the left was his wound when I first saw him. So when he entered rehab, it was 4.4 by 2.3 by 1 centimeter with some undermining toward 1 o'clock. One of the challenges that we had with the negative pressure on this wound, as much as it was a smaller wound, it was very simple. We didn't have to worry about any leaks or skin folds. So it should have been an easy negative pressure dressing to do. But what we were finding was the type of exudate that was coming out of this wound was very thick and mucousy, and it was clogging the tubes of the negative pressure system. So what we ended up doing was trying an irrigation. We added an irrigation port, and we were doing a normal saline irrigation at first. And then I remembered that we could use the Vache irrigation. So the normal saline irrigation didn't do a lot to soften that really thick exudate. But we added the Vache irrigation, and what we did was a 10-minute dwell in the negative pressure. And we found that it actually did help clean out a lot of that thick mucousy type of exudate, and it cleaned up the wound quite nicely. So now I think we're ready for some question and answers.